This one hasn't come on. Can I borrow a pen?
Negotiate how soon that you're going to be putting in tenant kernel.
Okay. No, after 3 years, can I start somewhere else? Can I say I want to move to Cuba, to wherever?
You're going to say, I would like to move these 3 places, rank 1, 2, and 3. Hopefully you get 1, 2, 3. See, but you, if you want to do
I'm going to be
Yeah.
limited.
you could probably get Turkey. That's the closest you're going to have.
Turkey will probably be fine.
But the other thing is, you guys are Poland.
Yeah.
You can get stationed in Germany and probably stay there for 2 to 4 years. Hello, sir. Yes, sir.
Now, second question. What would be a branch of service that
Air Force.
over the other?
Air Force. But the Air Force will let you where you get to go though. You'll have more opportunity to do some with it. I would go Air Force Navy.
All right, so let's get started. We have started a little late. I'm not sure I'll be able to finish the presentation, but I will try. All right, so this is a basic ultrasound lecture, which I had really prepared for the medical students and for some interns. But I presented it, and Dr. D suggested that I show it to all of you. And I do feel that some of this is very pertinent to us. In fact, most of it is pertinent to all of us, and we'll go from there. All right, so what are the advantages of ultrasound? It's easily available, it's portable, it's inexpensive, it's radiation-free, and it allows for dynamic imaging. What is dynamic imaging? You can have the patient do a cough maneuver, a Valsalva maneuver, decubitus scanning, supine scanning, so on and so forth, which is not possible with other CT or MRI, which is more static imaging. So that is really the advantages. And another big advantage that I didn't really list here is weight. There just has no table weight limit, unlike CT or MRI, where to have the patient mounted on the scanner, you will have to have a certain weight limit that is to be obeyed, but not with ultrasound. I mean, patients on their own stretcher, we can just about do our best. What are the disadvantages? Of course, large body habitus and more depth to the lesion would obscure imaging with ultrasound, and of course, the most important being operator dependent. And they say that your ultrasound report is probably as good as your worst ultrasound tech. So in the future, when all of you, go on and become radiologists of your own, and you have, your own practices, always invest in your technologists. Invest in them, invest time, education in them, because that is how an ultrasound department will really reign supreme. And when I came here 3 years ago, I was, our ultrasound department, it was really not streamlined, I would say. There were no protocols to go by, there was no call to order, things like that. But today I can tell you very confidently that this is one of the best ultrasound departments within the nation. It's definitely very competitive. It's far superseded what I had in Michigan. I mean, we are doing just about every exam there is to do. And once we acquire a elastography machine, we will be doing that too later this year. So I'm very proud of our ultrasound techs. And just remember, always invest in your technologists. Invest time, invest education in them, and it will really reward you. So what is this history? So basically, the ultrasound equipment rotates or revolves around this piezoelectric effect. And what is this piezoelectric device? It was developed by the Curies, the Marie Curie, et cetera, in 1880 using a natural quartz-like element. And ultrasound was first used in wartime in 1940, and it was first used in medical application in the 1950s. Ultrasound is a mechanical longitudinal wave with a frequency exceeding the upper limit of human hearing, which is 20,000 hertz or 20 kilohertz. So again, these are all exam questions. They can ask you wavelength, this, that, and the other. In medical imaging, we're pretty much using the 2 to 20 megahertz range, and that's when we're using. Remember, with patients really obese, you want to go down on the frequency. You're using more typical 3 to 5 megahertz transducers, and patient is either thin and you want to do more dedicated imaging, you want to go ahead, 10 to 12 to 13 megahertz transducer. So like any sound wave, the ultrasound wave also has its own characteristics. We will define as we go along velocity amplitude, wavelength, and frequency. And like any other wave, this is a sound wave, could be and it's, propagating in vacuum, and that's how it is shown to us. So we'll talk about each of these, how they ultimately affect image formation, and how having this knowledge can help us get better images in patients that may not be ideal. Velocity. So velocity is speed at which a sound wave travels through a medium. That's just the definition of velocity. It is determined by the density and stiffness of the media. So it is slowest in air or gas, and it is fastest in solids. Average speed of ultrasound in human body is about 1,540 meters per second. So this is, again, something that you'll need to know for the exam. So this is how we're defining speed, is nothing but how any wave or how this sound wave is traveling through a medium. What is frequency? That is number of cycles per second. We all know that. So the units are in hertz. Ultrasound imaging frequency, like I said, is between 2 and 20 megahertz. So that is the frequency of the sound wave. So it's very easy. So distance over which one cycle occurs. So how do you go from one trough to one peak to one peak, or one trough to one trough? And that will complete one imaging cycle. So this is a lower frequency. And how do you know that? Because the time taken to go from one peak to the next peak is longer. This is a higher frequency. As you can see that these are more close, the peaks and the trough. So that's a higher frequency, basically how many cycles per second, and that determines the frequency. Coming next to wavelength, distance over which one cycle occurs. That also is understandable. So this is a wavelength from one peak to one peak, one trough to one trough. This is the distance, and this is the height in centimeters of the wave itself. So this is a wavelength. And coming lastly to amplitude, it is the strength or intensity of a sound wave at any given time. It is represented as the height of a wave, decreases with increasing depth. So as you know, the amplitude of a wave as it comes through 2, 4, 6, 8, 10, 12 centimeters of body tissue gets attenuated, right? The amplitude goes down. So to compensate for this, we have something inbuilt in our machines, and that's called the TGC, the time gain compensation. So this is very important for us to know. All ultrasound equipment is based on the premise of the time gain compensation. What it says is that as the ultrasound beam, the incoming ultrasound beam, gets deeper and deeper into the tissues, the more it gets attenuated, right? All of you are with me? That's understandable. However, the returning sound wave that will go back from the deeper tissues back to the transducer, which will ultimately be responsible for forming the image, is accentuated, or it's as with deeper tissues. So if, let's say, the subcutaneous muscle or a muscle in the forearm returning echo will be 1x, but that from maybe the kidney will be 10x. So whatever is returning back to the probe is amplified based on how deep or how far it is away from the probe. Okay, that's the amplitude. So this is the decreases with increasing depth, and that's understandable. So again, this is putting everything together. This is the amplitude of the wave. This is the wavelength. Again, this is the wavelength, either peak to peak, trough to trough, so on and so forth. Any questions so far? Okay, good. All right, so what is false about ultrasound? Portability, easy availability, ionizing radiation, or operator dependence? How many for A? B? C? Okay, D. Good. Now, this is the piezoelectric effect, and many of you will ask me, where are these crystals located? They are located on the surface of the transducer. Okay, so if you have a transducer, which is this, they are located on the face of the transducer. Every transducer has a face, right, that you put on the skin of the patient. That is called the face of the transducer. So that's where these crystals are located, and they are very unique crystals because they can do this phenomenal thing, is that principle of converting energy by applying pressure to a crystal. So they are able to convert one form of energy to another form of energy when pressure is applied on them. And what is pressure applied on them? When they touch the skin surface or anything touches them. So they're able to change electrical energy, how an ultrasound machine is plugged into an outlet, right? It works from an ultrasound, from electrical energy, or it's charged, so it runs from a battery. So essentially, the ultrasound machine is running from electricity. But as soon as a piezoelectric crystal receives pressure, it changes electrical energy to sound energy. It causes formation of ultrasound. So electrical energy is converted to sound waves. That is the piezoelectric effect. That's the most basic. And how it causes this is, again, very well listed in your physics textbooks. It causes deformation of the shape of the crystal. And this deformation causes an imbalance of the crystalline architecture of that particular molecule, and therefore electrical energy is converted to sound waves. So this is the transducer, face of the transducer plugged into an electrical outlet right here, and this is changing the electrical energy into sound waves. Does that make sense? What is also very important to know is that same piezoelectric crystal can change the sound energy that is returning back to the probe from the patient's body into an ultrasound image. That is again converting it back into electricity. So it is a dual functioning crystal. Something very similar, that not only the incoming but the outgoing beam is also, the sound waves are reflected by the tissues. As you know, what is coming back from the tissues is what is forming the image. And that is also formed by this. Reflected sound waves are converted to electrical signals and later into an image, right? That makes sense? So electricity into sound, then sound into electricity. So that's what the crystal is doing. And then that electrical energy is manipulated by the system ultrasound machine into an image. All right, so the transducer contains the piezoelectric elements of crystal which produce the ultrasound pulses, as I explained to you. These elements convert electrical energy into a mechanical sound wave, ultrasound wave. So electrical energy converted into sound wave or mechanical energy. So very easy, same thing over here. The crystal is converting electrical energy into sound waves. The next very important thing that I want to speak to all of you about, and again this is also tested upon, is that the interactions of the ultrasound with every different tissue type or every different material is different. And the interactions, how different they are basically finally going to result in a different image. So the interactions of ultrasound with tissue could be reflection, transmission, attenuation, or scattering. So let's look at that. So these are the interactions of ultrasound with tissue. Attenuation. So the incoming beam is strong, but it totally gets attenuated and nothing is able to go through. The MSc, can you give me a structure that would cause total attenuation of the beam? Like you're not able to see anything beyond the anterior-most surface of that structure. Like you know that there's a structure there, but beyond that you can't see anything. It's a bunch of shadowing. Very good. So bone is a very good example. So you can ever try to put your probe on the femur or the tibia, you will see that you can see that there's an incoming beam and there's this white echogenic line. Beyond that there's a bunch of shadowing, nothing else returns. It's totally attenuated. Coming to absorption. Absorption means that there is a structure here that causes propagation of the ultrasound beam. The incoming beam is propagated, it's multiplied, it's amplified. Jared, would you be able to tell me what can cause absorption of the ultrasound beam?
Basically, any soft tissue.
More than soft tissue? Fluid. Like when we are using the uterus visualization, using ultrasound, using the bladder, urinary bladder, as an acoustic window to visualize a uterus, right? So you were using the absorption property of the interaction of ultrasound with fluid, urine in this case, that will cause amplification and no attenuation of the beam to go through all the way, so the uterus may be identified. Reflection. Reflection is most commonly seen in most of the soft tissues, liver, kidneys. They'll all cause some part of this will be reflected back, and that's the reason why the image is created. Coming to scattering, can anybody tell me that you see an incoming beam and then you see artifact that is radially going in all directions? Pardon?
Like a twinkle artifact with stone?
Very good. Stones, very good. So a stone artifact would cause that. And you would have a bunch of stones. You would not only have posterior shadowing, you can have shadowing even going laterally. And then you have refraction. This is yet another kind of wave that may occur through denser tissues, fibrous tissues. That's why, remember, in patients who have ovarian fibroma or thick fibrous tissue replacing a cirrhotic liver, you cannot see the liver very well. I keep telling you, the whole beam gets absorbed. There's hardly anything going back. That happens when there is refraction of the beam. And diffraction of the beam is an artifact that is used when we talk about side lobe artifacts, mirror image artifacts. they all use the property of diffraction. So if one knows basically what these interactions are and where they are created, it will be helpful to understand ultrasound in the future. So reflection. Reflection occurs at a boundary between two adjacent tissues or media. The amount of reflection depends on differences in acoustic impedance between the media, and ultrasound images formed from the reflected echo. So like I told you, reflection is the most common in ultrasound interaction with human tissue that is used to form an image. So reflection occurring on the surface of the kidney to that occurring on the surface of the liver are different. The angles of reflection are different, the amount reflected back is different, and therefore they look different on the ultrasound image. So this basically depends on the acoustic impedance of that tissue, of the kidney or the fat or the fluid or whatever it makes up. So this is just an easy example saying that, the source, the pulse is gone, it transmitted, comes back, and what is reflected is received back by the transducer to form the image. So always remember, if 100% of the ultrasound beam leaves the transducer face, 100%, you will be lucky or very happy if even 50% comes back. 30% is adequate to form the image, a good image, okay? So if you're in the very latest machines, etc., are amplifying this time gain compensation, that the deeper tissues like the kidney or the abdominal aorta, when you're scanning from the anterior abdominal wall, the amount that is reflected back is amplified from deeper tissues than from superficial tissues, and therefore you're able to get a good image. So scattering is redirection of sound in several directions caused by interaction with small reflector or a rough surface, like Daniel said, like with a rough surface. So that could be due to a stone or any coarse concretion calcification. Only a portion of the sound wave returns to the transducer because it is not coming back to the transducer, it's just going in all directions, so you'll be lucky to get 10-15% of it back. So this is scattering. Do remember one thing, that artifacts like posterior acoustic shadowing, scattering, etc. are very essential for us to know because they make us form a diagnosis without actually seeing the abnormality. I mean, so many times we don't actually visualize a stone. We just see a focal echo with shadowing and we assume that's a stone. So appreciating this was helpful. Transmission, okay? So not all the sound wave is reflected. Some continues into the deeper body. These waves will reflect from deeper tissue structures. So Jared, this is how urinary bladder helps us sing the uterus. So urinary bladder, because it's fluid, the acoustic impedance means how much hampering of the sound wave it will cause, impeding the sound wave. It has a very, very low acoustic impedance, urine or fluid. So it doesn't absorb any of that, it lets them go through, and now what you get is going to be from the deeper tissues because bladder is anterior to the uterus. Can someone tell me another very commonly performed clinical situation where we are using acoustic impedance to identify deeper tissues? Abdomen, in the abdomen.
Good, how are you?
How about when I say, if you want to visualize this organ, give this patient a cup of water. Pancreas, very good. So if you want to visualize the pancreas very well, and there's a whole bunch of gas within the distal gastric lumen, gastric antrum, and D1, give a patient a cup of water and make him sit up. That will displace the gas distally, and you can now use the fluid-filled stomach as an acoustic window to identify the pancreas, because pancreas is lying in the C-sweep, right? So that is another where you can use the phenomenon of transmission. So very similar, this is the probe, this is the image that is going through, and it is transmitted through here, like nerves, for example, the nerve. And can anybody tell me where we are using a nerve as an area for transmission into deeper tissues?
Use the optic nerve if you want to look at.
To look at what?
You can measure the vessels in the intracranial vessels for basis back.
Very good. You're using the optic nerve, very good, to look at as deeply as posterior to the posterior conus of the orbit. Very good. All right, attenuation. Attenuation, like we said, the deeper the wave travels in the body, the weaker it becomes. That's only understandable. The amplitude of the wave decreases with increasing depth. So we discussed that already. This is just a repetition. So the deeper first interface, second interface. So 100% beam can dwindle down to 1 or 0.5% as it comes to deeper tissues. So my question is, in a patient who probably is average like me maybe, and you want to visualize my abdominal aorta from the umbilicus, if we are banking on this dwindling wave to return back and come back to the probe, we're not going to see anything. That is again where time gain compensation is going to help us. Okay, so which is not an ultrasound interaction with soft tissue? Refraction, anyone? Anisotropy, anyone? No one? Attenuation and scattering. Any shout outs? Anisotropy. I never discussed anisotropy. It's just a fancy word in there, just to confuse you. Okay, time gain compensation. Increasing amplification of echoes from increasing tissue depths. It is used in ultrasound to correct for increased attenuation of sound with tissue depth. So has anybody seen on the ultrasound machine the TGC? Where is the TGC located on the ultrasound machine? What is it? Is it a knob? Good, it's a series of buttons. It's a series of buttons that are arranged in an array, like in a linear array. And they go from superficial to deep, right? And then you can change them. If you think you're not getting good echoes returning from a deeper tissue, increase your time gain compensation for deeper tissues. You will get better return. And at the same time, the superficial tissues will start appearing blurred. So having that knowledge of time gain compensation, sometimes the techs know it, sometimes the techs are overwhelmed, sometimes they are not aware, and you guys can help them out sometimes. So put on the TGC if you are particularly looking for something that is deeper down. What happened? What is the joke? Huh?
It was a
mean joke?
one of the texts.
One of the texts.
Said your texts are wonderful.
Yeah, my texts are wonderful. Okay.
Except for one or two examples.
Okay, acoustic properties. All right. Acoustic shadowing on an ultrasound image is characterized by a signal void behind structures that strongly absorb or reflect ultrasound waves. This happens most frequently with solid structures, as sound conducts most rapidly in areas where molecules are closely packed, such as bones or stones. You know that already. So this is, again, the gallbladder, and there's multiple acoustic shadowing that is happening from the gallstones. Again, renal stone right here. Some shadowing here, more shadowing here. Acoustic enhancement. This is a characteristic of fluid-filled structures such as cysts, the urinary bladder, and the gallbladder. The fluid only attenuates the sound less than the surrounding tissue. The time gain compensation overcompensates through the fluid-filled structure, causing deeper tissues to be brighter. Simply, it is seen in increasing echogenicity posterior to a cystic area, or increasing whiteness posterior to the cystic area. So right away you know, if this is the gallbladder, this is a simple cyst in the liver, and you can see more whiteness going through a cyst, you can confidently say that the contents of this are cystic, right? Likewise, this is a urinary bladder, you see more through transmission, and you can tell them that the contents of this are cystic.
Technically, you could adjust your TGC to remove that?
To remove it, yes, you could. You could.
But it would then amplify the other, relative to it.
When you change the TGC, like let's say you want to look at a deeper structure and you increase the TGC of the lower one, then don't expect on the same image parameters to have excellent view of the superficial tissues. Superficial tissues you should be able to see otherwise. This is a focal examination. Get your focal length down, focal spot to where your region of interest is, and increase your TGC. It'll answer the question in that deep area. Okay? All right, so mirror image artifact, ultrasonography is seen when there is a highly reflective surface, such as a diaphragm, in the path of a primary beam. How often do you see it? Very often. Any other examples of mirror image artifact? Bladder, more side lobe, anything else? You see this in the neonatal brain. Okay, in neonatal brain imaging, you can sometimes have anomalous appearance. If there's a dilated ventricle on one side, it can simulate a dilated ventricle on the other side. So you can have a mirror image artifact, and anything, it usually happens because the corpus callosum, the developing corpus callosum is a highly reflective surface like the diaphragm here. So this is the diaphragm, very reflective. If it comes in your path, it seems like the liver lesion is also present in the lower lung. reverberation artifact occurs when an ultrasound beam encounters two strong parallel reflectors, right? Two strong reflectors, and the ultrasound beam is seen between those two. When the ultrasound beam reflects back and forth between the reflectors, that is causing reverberation. So it reflects back and forth between two reflectors. The ultrasound transducer interprets the sound waves returning from the reverberation as deeper structures, since it took longer for the wave to return to the transducer. So what it basically means is that, let's say there are two reflectors, okay? Maybe the one is a diaphragm and one is the lung, okay? One is lung. So gas, for example, over here will give us some reverberation artifact. It'll oscillate between the diaphragm and the lung, that gas. And when it returns, finally it's done reverberating, it returns back to the transducer thinks, oh my God, this took like 3 milliseconds to return to me, so it must be a deeper structure. So it interprets this as a deeper structure. Does that make sense? The deeper the structure, the longer the time it will take to return back to the transducer. But when the reverberation artifact is happening, the time returning to the transducer is increased, and therefore it took longer for the wave to return to the transducer. Therefore, the resulting transducer interprets that this is coming from a deeper structure. So this is a reverberation artifact very commonly seen in patients who have diaphragm and patients who have air over here. Why would this air be here? Air is not encapsulated air. It's not air within the alveoli. This is a patient with pneumothorax. Okay, a patient with pneumothorax right here can have this oscillation or this reverberation. On real time, you will see that these are moving, right? Of course, for diagnosis of pneumothorax, you have all your A lines and A and D and whatever lines, but sometimes diagnosis is very possible when you can see the reverberation on real time. Sidelobe artifacts are multiple beams of low amplitude ultrasound energy that project radially from the beam axis. So something should come down, but it diverges, it erroneously gives us a larger size of that object or that mass than it normally should have because of the sidelobe artifact. So this is the sidelobe and grating artifacts that we talk about. So this is the transducer right here, this is the focal zone, and this is the main beam. But what is happening is that grating lobe artifacts don't contribute that much to image creation. That is one thing you need to know. The side lobe artifacts would artifactually cause amplification of the mass, and therefore the mass, which is normally 3 centimeters, will appear to be 1 centimeter anterior and 1 centimeter posterior extra. And the side lobe artifact will cause enlargement, artifactual enlargement of that mass. So right here, does everybody appreciate the side lobe artifact? So the normal confines of the mass would be like right here. This side lobe artifact is causing enlargement of this, artifactual enlargement of this mass. How can one remove side lobe artifact, Tom? Orthogonal imaging, very good. If you are doing sagittal, go at 90 degrees. Do transverse. If you're doing transverse, do the sagittal, or go orthogonal, go at a 45-degree angle. Side lobe artifacts will be eliminated if you change the angle of insonation. Transducer types, this is like a whole bouquet. There's so much that we have over here. And we have linear transducers. Those are high-frequency transducers, which we use to look in Dr. Simantini. I see the meat. We look at image all those superficial tissues, and masses and abscesses that are subcutaneous. The nerves, like the median nerve, etc., which Dr. Simantini looks at. These are endocavitary probes. Endocavitary probes can be either side-firing or end-firing. Does anybody know the difference between side-firing and end-firing probes? Name is different. What other than the name? What is different?
The end of it or the side.
The endovaginal, maybe where the surface is.
That's more of a prostate probe, right? The side.
Prostate.
Very good. So when you, exactly. So a transrectal truss probe, which is used for examination of the prostate, is usually side-firing because you're not really interested in the rectum because you're not going to see anything. So you only want to look anteriorly. When you're in the rectum, you only want to look anteriorly to the prostate. You don't want to look at the sacrum or anything. So that's true. This is a regular curvilinear probe. Look how the face is curved. And this is a lower frequency probe, 3 megahertz to 6 megahertz to 7 megahertz. Okay, this is used for abdominal imaging. Again, this is a linear probe like this one, but a smaller face. A smaller face is useful in pediatric patients, especially when you're doing fontanelle imaging and you want to go through narrow areas like fontanelles, etc. Same pediatric probe, pediatric probe. Anybody heard of the hockey stick probe? What does it do?
Very small, very high frequency probe.
Yes, it's a very high frequency probe of the order of 15 megahertz to 17 megahertz. And it can be used for dermis, epidermis imaging. So you're looking for a foreign body like a glass fragment or something right under the skin. You can feel it, but it's right under the skin. Is there anything you need to put between the hockey stick and the skin?
It's very superficial. You put a step of pad.
What do you put?
Step of pad.
Yes, very good, a step-off pad. What is a step-off pad? It's nothing but a block of gel, solidified gel that again has a phenomenon of transmission. It amplifies the incoming beam, will make you see the superficial tissues. That's number one. Number two, because you're trying to look for it, you will not inadvertently compress the area that much if you have a stand-off pad. It's fairly light.
Dr. Simosini uses the acoustic for tendons.
Yeah, it's very superficial, correct. Very, very easy, which you all should know by now. The frequency of the transducer and its effect on penetration. So they are inversely proportional, very easy. The higher the frequency, the less it can penetrate. The lower the frequency, the deeper it can penetrate. Attenuation is directly related to frequency. That's it. Higher the frequency, the more it will get attenuated. Lower the frequency, the less it will get attenuated. So do we have time? I can go through this also. I don't have a problem. Yeah, we do have time. All right, so this is basically trying to tell that there are these 5 types of echogenicities that are defined by ultrasound. You know, there's anechoic, which is no echoes. There's hypoechoic, which is a little bit of dark gray. Then you have isoechoic, which blends with the background. What is the background in the neck? What is our yardstick in the neck? Sternocleidomastoid muscle. Very good. What is our yardstick in the abdomen? What is it?
Fat?
So either it's the rectus abdominis or the iliopsoas. So again, it's muscle. All along it's muscle. Hyperechoic, when it's more bright than the isoechoic. And reflective is when you see just the anterior margin and a bunch of shadowing like bones and stones and so on and so forth. If you think this is too elementary, I can skip this. I have more at the end. But anechoic is basically no echoes, nothing at all through transmission. What is this artifact called, Hunter? Transmission, through transmission, that's all. Hypoechoic, it has some character inside this, right? So this is hypoechoic. Most solid masses or complex cystic masses may be hypoechoic. So cystic masses doesn't necessarily mean they are anechoic. If they are complex cystic masses like containing lymph or blood or pus, they may be anechoic. Isoechoic. Can anybody, will go on a date for coffee with me to the cafe if somebody tells me what is the diagnosis of this lesion, and I'm giving you the clue, it is isoechoic. And I have shown this on my previous lectures. This is the only lesion or only mass lesion in the liver that is very difficult to identify from the remainder of the liver, and one can just sweep through the entire ultrasound and not identify it unless you put on color and identify mass effect.
Focal nodular?
Very good. This is FNH, also called the stealth lesion. It is stealth lesion like the stealth aircraft. So Abraham and I will go to the cafe for a coffee. Very good. This is a stealth lesion. So when it's bare, all you need to know is that there is a change of texture from normal liver to abnormal liver. Other than that, it's very imperceptible. And when you put on color, arc-like vascularity on the periphery or increased vascularity in this vis-a-vis this is the only clue. This is called the stealth lesion. This is characteristic of a focal nodular hyperplasia. Hyperechoic, when there are more echogenic than the muscles here. So this is a hyperechoic. That is understandable. And then this is, again, hyperechoic with that reflection artifact. Okay, what best describes the echogenicity of this lesion? Right here. Anechoic, isoechoic, hypoechoic, hyperechoic. Hypoechoic, very good, because it's got some character in it. It's got some dots and dashes in it. Very good. All right, this is just some examples that I had. This is just ascites, and this is more complex ascites, which could be hemorrhagic ascites right here, more septated. this is pneumobilia. What is the easiest way to tell pneumobilia from portal venous gas? Is P for P, peripheral for portal. Just remember that, you will automatically know the other one. The more peripheral, it's likely portal. The more central, more biliary. Does that make sense? Double check that for me, but I'm 100% P for P. That's how I remembered it. Okay? Yeah, P for P, so gas. This is again bone, trying to show a subtle fracture over here with a small hematoma. So can ultrasound confidently identify fractures? Yes, provided there is a focal area to be interrogated. I mean, you can't give thus a whole femur to, whatever. But if you're saying, we think it's in the finger, yes, ultrasound can confidently identify, provided pain control has been managed and patient will allow us to, push a little bit on the fracture. So this is an area of the fracture with a small hematoma, which was on the finger. Again, soft tissue, lobulated margins, hypoechoic, internal echoes, again, soft tissue, modes of ultrasound. I don't think this is essential for you. All right, thank you.
Wonderful.
Thank you. I hope, sorry if it was too basic, but I thought we can.
This is very good.
Not basic?
Nobody